Good evening, all. Thank you, organizers, for this opportunity. I will be talking about the therapy post progression on immunotherapy plus or minus chemotherapy in non-small cell lung cancer. First, talking about the second line, these are basically pre-treated patients with reduced performance status. So the tolerability is an issue, and these patients also have a low response rate, and these are generally more symptomatic. So it is very hard to show any benefit in these cases, basically. So in studies, approximately 50% of the patients did not receive the second line therapy. So our motive should be the first line should be the best treatment always in these cases. So we can divide the time period for the second line therapy as per the onset of immunotherapy era. Before immunotherapy, it was basically either TKI or the chemotherapy, with the median PFS ranging from 2 to 4.5 months, and the median OS ranging from basically 5 to 10 months. During immunotherapy, we have 4 trials basically of Nivo or pembrolizumab and atezolizumab, and the median OS was approximately 10 to 11 months with these immunotherapies. However, we should also note that there is a tail which is straight basically in the immunotherapy arm, which is not seen in chemotherapy. So 20 to 30% of these patients on immunotherapy will be long-term responders. So after immunotherapy, that is the today era, we generally tend to use immunotherapy in the first line if the patient is fit and affordable. So progression wise, basically there are three scenarios. First is patient has progressed after immunotherapy, and there is slow progression and it is asymptomatic with a good tolerance to the prior immunotherapy. So first we should know few terminologies like progression, which is defined as per the different criteria like RECIST, IRRC, IR RECIST or IM RECIST. Generally it is defined as 20 or more percent increase from the nadir with at least 5 mm increase or appearance of the new lesions, and in the immunotherapy setting it should be confirmed with a repeat scan after at least 4 weeks. Then comes the hyperprogression. Hyperprogression is basically used along with the RECIST and the TGR or TGK. TGR is basically tumor growth rate. TGK is tumor growth kinetics. So hyperprogression is generally defined as the TGR or TGK of at least 2. At least 2 is basically used for defining hyperprogression. That is the tumor growth rate after starting the immunotherapy has doubled. However, it is very difficult to differentiate hyperprogression from the pseudoprogression. So there are some other criteria also which include the tumor burden, progression rate, or the ECOG PS decrease of at least 2 points. Pseudoprogression is basically transient enlargement of the tumor before regressing. It is generally due to the inflammatory reaction. Oligoprogression has no clear-cut definition, but small progressions with control at other sites is basically oligoprogression, and the sites and number vary from 2 to 5 in different trials. So we can see the hyperprogression is basically rapidly increasing. Pseudoprogression, it initially increases, then it decreases. The only way to differentiate these two is basically doing the biopsy. So coming to the first scenario, can we continue the immunotherapy after asymptomatic or slow progression? This was a basically exploratory analysis of the OAK phase 3 trial, in which they have used basically after at least one line of chemotherapy, and they have used atezolizumab or dosi, and after asymptomatic progression they have continued the atezo or used the non-protocol therapy. With the use of atezo post progression, there was a significant benefit in the OS. Second scenario is basically oligoprogression, that is progression at few sites while the disease is controlled at most of the sites. So oligoprogression is not very uncommon. It accounts to approximately half of the progression after immunotherapy, and oligoprogression has generally good prognosis compared to the systemic progression. The PFS2, which was explained by a Chinese study, was 13.1 versus 10 months in the oligoprogression and the systemic progression, and it was 26 versus 19 months for the OS. So in that trial, they have given local therapy for approximately 1/3 of the patients, and with the addition of local therapy, the PFS has increased to 15 months compared to the 10 months. That is approximately 150% benefit with the addition of local therapy. Similarly, the OS has increased. Now comes the last scenario, that is gross progression or the systemic progression. Can we re-challenge the immunotherapy? So this was a pooled analysis of 5 keynote trials, and there were patients who received at least 2 years of pembro without any progression, or stopped pembro due to any intolerability, or they attained CR and those were stopped. These were included. So in the cohort 1, it was only the immunotherapy which was re-challenged, and in the cohort 2 it was chemo plus immunotherapy. And the striking point was basically in the cohort 1, the TPS 50% was seen in most of the patients, while chemo was added in few patients. So the PFS was almost similar, so was the OS, but the response rate was slightly better in the IO arm, maybe because of the high incidence of the PD-L1 high expression. So this was another retrospective trial from the France basically, which was published in 2020. So they have analyzed 10,000 patients, in which they have given nivolumab in the second line and re-challenged after either stopping the immunotherapy or giving at least one line of chemotherapy. We can see approximately 15 patients of the total patients, that is 1,500 out of the 10,000 were eligible for the immunotherapy re-challenge. So this is very small number, and the median OS in the non-squamous arm was 12.5, while it was 10.5 months approximately for the squamous arm. Coming to the OS2, that is from the start of the immunotherapy to the death or the censoring, it was better than the OS1, mostly because the good biology was selected and these were given basically immunotherapy. So those patients in which the immunotherapy, that is nivolumab, was given for more than 6 months, they fared better than those patients who were given less cycles of immunotherapy. So angiogenesis is also seen as a mechanism of immunosuppression. So there are trials which show that addition of anti-angiogenesis agents like ramucirumab basically improves the outcome compared to the chemotherapy. These are basically ongoing trials which are checking different agents after progression of the immunotherapy. So second line treatment is an effective, so it should be offered to all the eligible patients, and we should be able to beat the 50% for the second line, and it is yet to change the treatment paradigm. Thank you.